This is Stephanie Huff, and I am recording the Pharmacology for Oxygenation lecture. We're going to go over asthma and COPD medications in this lecture. First thing we're going to talk about is the group known as adrenergic stimulants. They are bronchodilators. In this class, indications would be for to provide bronchodilation to control and prevent reversible airway obstruction that's caused by asthma or COPD. When inhaled, this medication is used for a quick relief for bronchospasms. So these are quick relief medications. So basically, if they need a rescue inhaler or treatment, this is the type of drug that they will use. It can be used orally for long-term control of a chronic persistent bronchospasm. It can be given by an MDI, which is your metered dose inhaler, or a dry powder inhalation. This is the treatment of choice for acute bronchial asthma. Action of this drug, it affects the sympathetic receptors in the respiratory tract, most selectively the active beta-2 receptors, and this results in a smooth muscle relaxation and bronchodilation. Some of your side effects that you will see with the adrenergic stimulants are going to be nervousness, restlessness, tremors, headache. Insomnia is more common in children than it is in adults. It also causes lots of hyperactivity in children, and so that can be kind of aggravating to the parents. They may have some chest pain, palpitations, angina-type pains, arrhythmias, hypertension. GI is going to be like nausea, vomiting. They can cause hyperglycemia, so you have to be careful with your patients that are diabetics. A lot of times they'll need adjustment of their medications. Also, tremors kind of go along with it, and hypokalemia. When these medications are given orally or parenterally, they have lots of undesired side effects. So often the people can't tolerate the side effects and don't want to take it where it goes systemic. Patient teaching for adrenergic stimulants, a lot of it is going to be directed per the healthcare provider, and that may depend on some of their other comorbidities that they may have. They need to contact their healthcare provider immediately if their shortness of breath is not relieved by the medication. This is when they become into a dangerous situation. A lot of times they'll use a spacer, which is put on the end of the inhaler, and it actually holds the medication in there so that the patient can better get all the medication and it is not wasted. Your adrenergics are used first before any anticholinergic or steroid. You always use bronchodilators first before any other type of inhaler is given, because you want to dilate those airways first so that the other medications will work better. Bronchodilators also work a lot faster. When using it as an MDI, you want to wait 2 to 3 minutes between their puffs. And this will help allow the airways to fully dilate. They need to rinse their mouth to decrease the systemic effects. If you're given different medications, a lot of times they'll wait 5 minutes apart. They need to report any palpitations, irregular pulse, or other side effects to their healthcare provider. Alright, also avoid using MAOIs because that could lead to a hypertensive crisis. If patients already have hypertension, cardiovascular disease, dysrhythmias, hyperthyroidism, or diabetes, you also want to use caution. A lot of times they'll have to have adjustments of their medications. You want to observe for paradoxical bronchospasms, which is wheezing. You also want to assess for the effectiveness of the medication, and so your desired effects are going to be reduced dyspnea and wheezing. So some of the examples of this group is going to be albuterol. Your trade names are Provenal and Ventolin. Metoprolol is Alupent. Salmeterol, Ceravent. And terbutaline is Brethine. Some of your combination products in this class are going to be an albuterol, ipratropium, which is Compavent, and a salmeterol and fluticasone fluticasone is Advair, and that's the purple disc that has become quite common. Alright, next class is going to be mexylxanthines. Indications for this are long-term control of reversible airway obstruction that's caused by asthma, chronic obstructive pulmonary disease. It was once used to prevent and treat asthma attacks, but now it's used primarily just to prevent nocturnal asthma in affected adult clients. Action of this medication, the central nervous system stimulant chemically, it is a CNS stimulant that is chemically related to caffeine. So it will produce bronchodilation through relaxation of those bronchial smooth muscles. Alright, so some of your adverse effects of your mexylxanthines are going to be seizures, and that's especially when they're given in large doses. Anxiety, headache, insomnia, nervousness. Cardiovascular, you'll have arrhythmias, angina, tachycardia and palpitations, GI, nausea, vomiting, anorexia and cramps, neuros, tremors, and you can see how these, a lot of these side effects are similar to those adrenergic stimulants, but these also cause bronchodilation as well. Some of your examples are theophylline and aminophylline. Your theophylline has a narrow margin of safety and high potential for toxicity. This is affected by such things as age, smoking, genetic factors, alcoholism, and other chronic diseases. So monitoring their serum blood levels is critical. Alright, patient teaching. Oral doses need to be taken at a prescribed time. A lot of times they'll give them with meals or a full glass of water or milk to minimize gastric irritation. Also says to increase the water to at least 8 ounce glasses a day, avoiding caffeine and alcohol while they're on this medication. A lot of times these oral mexylxanthines are ineffective in treating an acute asthma attacks. They do not delay other treatment by using these drugs. So if it's an acute attack, the orals are going to take way too long to take into effect. So what they're basically saying is go ahead and start your other treatments before you give this orally. You need to check with the physician before taking any over-the-counter medications or any other prescription medications while on theophylline. A lot of times theophylline has a adverse effect with other medications. Do not smoke while using this drug. If somebody already is smoking when they start using this drug and then they stop it, they need to make sure that they tell their doctor, because they may need a dosage adjustment to prevent toxicity. And again, reporting adverse effects to the doctor and needing regular blood work to determine drug levels. Alright, so still talking about the mexylxanthines, therapeutic drug levels for theophylline in adults, it is 5 to 20 micrograms per milliliter. In elderly, it is 5 to 18 micrograms per milliliter. Low levels precipitate bronchospasm. High levels will result in toxicity, so you have to really, it's a fine line in that margin that you want to stay closely in. Signs of toxicity would be anorexia, nausea, vomiting, restlessness, insomnia, cardiac dysrhythmias, and seizures are going to be your earliest symptoms. Other symptoms are going to be epigastric pain, hemoptymesis, which is coughing up blood, diarrhea, headache, irritability, muscle twitching, palpitations, tachycardia, flushing, and circulatory failure. You want to monitor closely when they're given with other medications such as barbiturates, anticonvulsants, thyroid hormone, beta blockers, and bronchodilators. Aminophylline is also incompatible with many other IV drugs, so they suggest using a separate line if you can. If not, then you have to flush the line with normal saline before and after administering any other medications. And they usually recommend at least 10 milliliters of flush before and after. Alright, so now we're on to anticholinergics. These are potent bronchodilators. So it blocks the muscarinic receptors of the parasitic nervous system. And so by blocking the muscarinic receptors, this will facilitate smooth muscle relaxation and bronchodilation. And so if you didn't block them, then these muscarinic receptors produce smooth muscle contraction and bronchoconstriction, so it's quite the opposite. Some of your examples of drugs, atropine is the first one. It's used infrequently because of the tendency to dry secretions of the mucous membranes and other side effects. Your ipratropium bromide, which is your Atrovent, and your tiotropium bromide, which is Spiriva, those are both available as inhalers and have fewer side effects than the atropine does. So a lot of times they'll use those first. Combination product for this group is albuterol and ipratropium, which is your Comavent. So nursing considerations with anticholinergics. You want to assess for contraindications to the drug. So things you're looking for are hypersensitivity, glaucoma, prostatic hypertrophy, bladder neck obstruction. Assess for desired outcome and or side effects. So you want to improve symptoms and not worsen symptoms. If the symptoms get worse, then we need to address that. Also, some of your side effects are going to be nausea, vomiting, abdominal cramping, anxiety, dizziness, and headaches. Provide ice chips, fluids, or hard candy to relieve the dry mouth. Patient teaching. Take no more than the prescribed number of doses a day. A lot of times with these medications, patients will take more than is prescribed. They think it's going to help them better. And educate them only to take as prescribed to prevent overdosing. If the drug becomes less effective over time, we need to notify the physician because they may need a change in their dosage. All right, corticosteroids. These have an anti-inflammatory effect, both prevent and treat acute episodes. Action is to decreases the synthesis and release of inflammatory mediators, and this is going to be histamine and leukotrienes. It also reduces inflammatory cell activation and decreases airway edema. It also decreases the mucus production in the airway. These are used to reduce the frequency and severity of asthma attacks and to allow reduced dosages of other drugs. So a lot of times they'll use these in combination. A major concern with corticosteroids is this cushingoid side effect, which is also adrenal crisis. It's a major concern. This is minimized when it's inhaled because that means the drug does not go systemic. You will see that a lot more often when they are on these corticosteroids long term and they stop them abruptly. It can throw them into that adrenal crisis, and so they have to taper off the dose for that. So that's one of the really important things about corticosteroids. All right, so some of your examples: beclomethasone, dipropionate, which is your Vanseril and Beclovent, triamcinolone acetonide is Asmacort, flunisolide is Aerobid, fluticasone propionate is Flovent, dexamethasone sodium phosphate is Decadron phosphate, Respihaler. Combination products is your Samlotrol fluticasone, which is your Advair. It is associated with increased risk of serious asthma exacerbations and death, so it's only recommended for use when asthma is inadequately controlled using other medications or for patients who clearly require both a bronchodilator and an inhaled corticosteroid for managing their asthma. So nursing considerations: administer doses after bronchodilators to facilitate transport of the medication to the distal airways, because you want that bronchodilation first. Assess for common side effects, which will include sore throat, hoarseness, oropharyngeal or laryngeal Candida albicans infection, which is a yeast infection. You can administer antifungal meds to help clear this up, or gargles as ordered. A lot of times if they will do gargles after they use it, that will cut down on that risk of Candida albicans. Alright, patient teaching. Again, rinse in the mouth after using an inhaler. Maintain good oral hygiene to reduce the risk of fungal infections. These meds should not be used to alleviate symptoms of an acute attack. Remember, these are going to take a little bit longer to take effect than your bronchodilators. So bronchodilators are your first drug to use for acute attacks. It may take several weeks to notice benefits of therapy. Notify the physician for any weight gain, fluid retention, muscle weakness, redistribution of fat, or mood changes. Alright, so this is broken down in your book for short-term and long-term side effects. So this is if they were taking oral corticosteroids for a short term. They've got glaucoma, fluid retention, swelling in their lower legs, hypertension, mood swings, weight gain, which would be fat deposits in the abdomen, face, and the back of the neck. They have included hyperglycemia in the long term, but even with short term, if your patient is a diabetic, it does raise their blood sugar levels, so they do need to monitor their blood sugars more frequently while they are on corticosteroids. So long-term effects, in addition to the hyperglycemia, are going to be cataracts, increased risk of infections, osteoporosis, increased risk of fat fractures, suppression of the adrenal gland hormone production, and that's that adrenal crisis when you abruptly stop it, bruising, thin skin, and you have probably all seen people that have been on oral steroids for an extended period of time, and they do have that weight gain and bruised, thin skin. They also have delayed wound healing, and it can cause growth suppression in children. So corticosteroids do kind of make them immunosuppressed, so it makes them more at risk for these infections, and that's also an important factor to know, in addition to tapering off the dose and the hyperglycemia that you really need to watch for. Most of these side effects will generally resolve once the medication is discontinued. It may take a little bit longer for the side effects to go away when they're taking them long term. Alright, so the next group we'll talk about is your mast cell stabilizers. These will inhibit inflammatory cells in the airway, thus blocking early and late responses to inhaled antigens. The action is that it will prevent cells from releasing inflammatory mediators such as histamine. So we're not going to have that histamine release. It is only used for preventing an attack, not to treat an acute attack. Mast cell stabilizers are used, administered by MDI, and again, that's your meter dose inhaler. There is a wide margin of safety in these medications. Drug examples for mast cell stabilizers: cromolyn sodium, which is your Entyl or nasal chrome; nitochromyl, which is Tylade; the patients that take that Tylade, they may complain of an unpleasant taste in their mouth after they use it. Nursing considerations: evaluate for potential adverse effects. Wheezing and bronchoconstriction also needs to be observed for. Patient teaching: gargling or sipping water can decrease throat irritation associated with the nebulizer treatment. You want to use appropriate technique, which is to inhale deeply with the head tipped back to open the airways. And this is after they've administered the MDI. They're going to inhale deeply. They're going to hold their breath for a few seconds to get it to fully dissipate in the lungs, and then they will exhale. And then they will repeat this until all of the drug has been inhaled. And that's when they use those spacers. Only used to prevent attack, not effective in treating an acute attack. And that was on the slide before, so that's important to know. May take several weeks for beneficial effects to be noted. Alright, your leukotriene modifiers, these will interfere with inflammatory processes in the airways by first suppressing effects of the leukotrienes, and that is a group of inflammatory mediators. I think we mentioned that before. Leukotrienes are powerful bronchoconstrictors and vasodilators. Alright, so the action is that we are going to block the leukotriene synthesis or receptors so that it improves their airflow, it decreases their symptoms, and reduces the need for short-acting bronchodilators. So this is a long-acting bronchodilator. These are used for maintenance therapy in adults and children over the 12 years of age as an alternative to inhaled corticosteroids. Again, not used to treat an acute attack. Some of your drug examples, your montelukast is your Singulair, zafralukast is Accolate, Xoliton is Zyflo. Nursing consideration, you want to administer at least 1 hour before or 2 hours after meals. So this is one of the ones that you don't want to give with meals. Drugs will inhibit some liver enzymes affecting the metabolism of warfarin and possibly theophylline. You want to monitor prothrombin times and theophylline levels. You want to monitor liver enzymes because it may be toxic to the liver. Patient teaching takes drugs as prescribed on an empty stomach. Notify the physician of any changes in the color of the stools or urine, and if they notice any jaundice, which is usually related to the liver being toxic. Alright, so now we're going to talk a little bit about allergy, cold, and cough remedies. These are your antihistamines. Indication is relief of symptoms of seasonal allergic rhinitis. It's also management of chronic idiopathic urticaria, which is where they have patches of like whelps that move from one place to another in their body. It'll come up in one place and then that whelp will go away and then come up in another place, and these areas do tend to itch. The action is antagonize the effects of histamine at the peripheral histamine H1 receptors, and it has a drying effect of the nasal mucosa, so it helps with that allergic rhinitis, which is just where their nose is just constantly running. Your adverse reaction side effects, you will have drowsiness and fatigue, dyspepsia, dysmenorrhea. Alright, so some of your teaching: avoid driving if the drug causes drowsiness, administer with milk or water to decrease the GI irritation. You want to make sure that they're drinking plenty of fluids to decrease the viscosity of the secretion, so they recommend about 1,500 to 2,000 milliliters a day unless it's contraindicated. You want to assess their lung sounds and the character of their bronchial secretions, because it should be drying those up. Assess allergy symptoms before and during treatment. Medication can cause false negative reactions on allergy skin test. Some books will say discontinue 3 days before testing, but most allergists will make you discontinue these meds for at least a week before they do any allergy testing or any other testing. Alright, and then there are some non-drowsy versions on the market. Your loratadine is your Claritin, which is probably the most common, Alavert and Tavist. Cetirizine is Zyrtec. It is also a non-drowsy. Fexofenadine is Allegra. Hydroxyzine is Atarax and Vistaril. Those usually tend to cause drowsiness, but they are really good to help with that itching as well. Then you have your diphenhydramine, which is your Benadryl, Sominex, and again, those tend to cause drowsiness. Some children, they may have an opposite effect. Some kids get very wired on Benadryl. Even some adults get wired on Benadryl, but you see it more often in kids. Alright, so your mucolytic or your expectorant drugs, Generic would be your guaifenesin. Trade names are Robitussin, Hitus, Mucinex, and Guaitus. A lot of times you can find these in the mixtures of your allergy, cold, and cough remedies. They are expectorants. Some you can get just by themselves. Action is to reduce the viscosity and tenaciousness of the secretions by increasing respiratory tract fluid, and so that makes them not as thick, so they're easier to cough up. Side effects, CNS will be dizziness and headaches. GI may have some nausea, vomiting, and diarrhea. Stomach pain. Dermatologic, you may have a rash or urticaria. You want to give the medication with a full glass of fluid, assess their lung sounds, encourage them to turn, cough, and deep breathe, and assess the effectiveness of that productive cough, and looking at the colors to make sure that there's no infection. Alright, so these are the drugs for asthma and COPD. The drugs that they use for both disease processes are the same. If y'all have questions, please let me know, and I will see if I can clear things up for you.